Good afternoon. So in this talk I'll be majorly saying whether there is any role of antifibrotics in glaucoma implants. Now antifibrotics, the subconjunctival and subscleral fibrosis is the main reason for any filtration failure. So the rationale for use of antifibrotics is to maximize conjunctival healing and inhibit scar formation in the BLEB. Till date, corticosteroids, mitomycin, 5-fluoro-uracil have been used as antifibrotics. Nowadays, there has been reported use of anti-VEGF agent bevacizumab. Mitomycin and 5-fluoro-uracil both have been proved to be efficacious in various randomized trials. Mitomycin is isolated from streptomyces and it is an anti-neoplastic antibiotic. It inhibits the tissue fibroblast proliferation. It is used in the dose of 0.2 to 0.5 mg per ml soaked in sponges applied to the surgical site. It has complications like overfiltration, wound leaks and corneal endothelial toxicity. 5-fluoro-uracil is a pyrimidine analog. It is an antimetabolite which acts by blocking the DNA synthesis by inhibiting the enzyme thymidylate synthetase. This also inhibits the tissue fibroblast proliferation. 5-fluoro-uracil is used in the dose of 5 mg as a subconjunctival injection. It also causes wound leaks and has more likelihood of causing a corneal epithelial toxicity. Both these agents have shown similar efficacy in short and long term with similar complication rates. However, two randomized trials have shown mitomycin to be more efficacious than 5-FU, the complication rates being similar. So how do we use? It can be used intraoperatively or postoperatively. In intraoperative antifibrotics, there have been studies with the Molteno and the Ahmed valve. Both have found no significant differences with or without the use of antifibrotics in an implant. BLEB encapsulation and fibrosis have been the primary mechanisms for BLEB failure, and antifibrotic agents have proven to be of great assistance. A little bit about BLEB encapsulation. It can develop anytime within 2 to 6 months, usually in the first month. The hypertensive phase is an inflammatory response of aqueous to the BLEB wall, as Dr. Mayuri said in the earlier lecture. Reducing the flow of aqueous in the early post-op period can reduce the incidence of the hypertensive phase. This occurs due to tissue remodeling as part of the wound healing process. The mechanism of action of encapsulation is thought to be micro movements of the plate of the implant with the sclera, which triggers a low-grade inflammatory reaction, along with the end plate material, which also has a role. Immunohistochemistry studies have shown increased expression of fibronectin, tenacin and smooth muscle actin in the walls of non-functioning BLEBs. There is also an increased amount of type 4 collagen and laminin. Needling has been an established procedure to treat encapsulation, which can be combined with antifibrotic use. For BLEB needling, there have been equivocal results in BLEB needling with and without the use of antifibrotics. The surface area of the implant plays a significant role in the success of needling. So to end, needling revision can be useful in the management of poorly functioning BLEBs. The risk for severe complications does exist, but this treatment modality needs to be explored further. However, it can be tried in cases before suggesting a second surgery. Thank you.
Thank you, Dr. Janvi. So the next talk is on the future of the aqueous drainage